My name is Jiun Kang, and I work at Seoul National University Hospital. It's an honor to have a speak at the Winter Coax Symposium, and I thank all committee members for inviting me. Today, my topic is going to be, as you see, aspirin versus clopidogrel in long-term maintenance monotherapy after PCI, and I will focus on the fact of generalizable or limited to East Asian patients. First, as a short introduction, we all know that long-term management is very important, not only limited to antiplatelets, but also other risk factors that we consider as high-risk patients for coronary artery disease. Usually, most studies have focused on within 1 year post-PCI, which was nicely presented by Dr. Han. And we know that the bleeding risk is the main contributor in the antiplatelet therapy, which was also mentioned by Dr. Meran in the first topic. However, limited evidence is shown how should we treat patients post-PCI after the first year. So regarding the guidelines, we can see that aspirin monotherapy lifelong was recommended as a class 1 level of evidence A. It is interesting to see that the level of evidence is A, despite that we have no randomized control trials that have compared aspirin versus other alternative treatments that we have in the current era. Regarding the recent 2023 ESC guideline, we see that the class 1 is still consistent, while aspirin is recommended the first-line therapy in long-term management for antiplatelet therapy. However, regarding the position of aspirin, it's clearly on controversy, both on efficacy and the safety. Can aspirin decrease thrombotic events, which is an efficacy issue? This was nightly shown in the ARRIVE ASCENT Aspirin trial, which was also, this was primary prevention patients, but it showed that aspirin had no effect in the efficacy aspect, while there was a consideration of high bleeding risk in those who are quite healthy. That means that who are in the primary prevention era. This can be extrapolated to the patients in the secondary prevention era, which means that aspirin may not be efficacious in those in secondary prevention. Regarding the safety issue, we all know that the aspirin has many aspects in the safety issue, which can be represented as the high bleeding risk. And are these safety issues should these be tolerated when aspirin has a minimal effect in the efficacy? This is a very important issue that we should consider. There has been a lot of trials that have evaluated aspirin versus clopidogrel. Most were conducted in the long term, in quite a long time ago, or retrospective studies, but all showed that clopidogrel was better than aspirin compared to a lot of aspects. So I would like to state that the stature of aspirin, which is threatened right now, was not by an ethnic issue, and clopidogrel as an alternative aspirin was not also raised by Asians, because this is my topic today. So based on this kind of hypothesis, we did the HOS exam trial, which was presented in the previous session, and I would like to just fly through the results. This was a randomized control trial which compared aspirin versus clopidogrel in stable CAD patients. That means that these patients were event-free during the first year after PCI, and these patients needed a lifelong antiplatelet agents to prevent any kind of secondary events. The events showed that clopidogrel was superior compared to aspirin with a risk difference of 2%, which means that the number needed to treat was 50, which was a quite small number. Thrombotic endpoints and bleeding endpoints were both superior for clopidogrel compared to aspirin, which is a very interesting finding that we see in a lot of antiplatelet studies these days, showing that a single therapy is better in both thrombotic and bleeding endpoints compared to the comparator arm. This was also extended to a six-year follow-up, which was named as the HOST exam extended trial, which showed that, which compared the aspirin and clopidogrel arm for a long-term period. Because this study was done on a per protocol analysis, we can see that the number were quite slightly decreased, but still a majority of the patients were followed up during the 6-year follow-up period. Interestingly, also, we could see that because this was a PP analysis, from the ITT analysis, we could see that a larger number of aspirin patients were converted to clopidogrel due to various causes. In the extended arm, we could see that still during the 6-year follow-up period that the clopidogrel arm was superior compared to the aspirin arm, which was consistent in the landmark analysis, again showing that long-term management is very important in the CAD patients that we treat. Also in the thrombotic endpoint and bleeding endpoint, we could still see that clopidogrel was better than aspirin, showing that the superiority of clopidogrel compared to aspirin was not an incidental finding that was found in the early period after PCI, but it was accumulated during the long-term period after PCI, showing that clopidogrel might be a better agent compared to aspirin in treating patients in the long-term period. Also, in the mortality issue, there was a slightly reduction, though not statistically significant, by aspirin compared to clopidogrel in the 2-year follow-up period. But regarding the long-term period, we could see that there was no difference in mortality issue, which shows that clopidogrel and aspirin, there's no difference in mortality in the stable CAD patients that we treat for secondary prevention. So then the remaining issues is the ethnicity. Is ethnicity an important issue when we should consider these kinds of agents? Because obviously a lot of trials are performed in a certain aspect of the world, and can we apply these kinds of results to other ethnicities? So first, to go into this issue, if we want to say that this is not applicable to other ethnicities, this is making a statement that there is a potential difference across ethnicities, which is very large. That means that ethnicity is one of the major contributors that we should consider when determining a certain treatment. However, in the guidelines, again, ethnicity or race is a very seldomly stressed issue in the guidelines. All stress, ischemic risk, bleeding risk, and sometimes the minority ethnicity may be considered as an aspect, but it's obviously not a very major issue. Also, we know that a lot of trials are done in a single ethnicity, but also a lot of trials are done in a multi-ethnicity. So in these kinds of trials, how can we interpret the results if ethnicity were to be a very important issue? Of course, ethnicity could matter in comparison of two antithrombotic therapies with different intensities, such as, well, let's say dual antiplatelet therapy compared to single antiplatelet therapies, because a certain ethnicity may be slightly more ischemic or slightly more prone to bleeding. However, the comparison aspirin versus clopidogrel was not this kind of issue. Also, this may matter when we compare a single diagnostic measurement as a cutoff value, such as a PRU value. But again, aspirin versus clopidogrel is not an issue that compares a single diagnostic measurement. Also, regarding ethnicity, if we go in one step into ethnicity, what is ethnicity? Can we define ethnicity as a very important issue? If the ethnicity is very diverse, is there a single ethnicity? Can we define a single ethnicity by the skin color? Of course not. Also, we can see from this slide that most of the patients are worldwide are definition-wise Asian patients, but within Asian, there's Southeast Asian, there's Northeast Asian, there's Central Asia, which are very different patient populations. We can see that the Homo sapiens has moved a lot around the world, which shows that it's very difficult to define ethnicity. And also, even in the US, we all know that the US is a multi-ethnicity country. However, the white people are decreasing. And again, the white is not an ethnicity. This is just skin color, which is very different from ethnicity. So I would like to state that in the guidelines, ethnicity is a very minor issue, while the high-risk group is a very important issue, which is stated much more commonly in the guidelines, and this can be answered by subgroup analysis of the host exam or extended trial. So regarding the high-risk population, we all know that ACS and CCS is a very important issue in determining the intensity, determining the duration of antiplatelet therapy. Then is the initial presentation of ACS, is this any major determinant in the antiplatelet therapy after the patient is stabilized? So within the host exam trial, we did a subgroup analysis which divided those patients with ACS and without ACS. From this analysis, we can see that there is no difference, which means that the P4 interaction is very negative in regards of the primary endpoint, despite the patients with ACS or non-ACS, comparing aspirin versus clopidogrel, which can be interpreted that clopidogrel's monotherapy is superior compared to aspirin therapy, despite the initial presentation of ACS. Going into the thrombotic and bleeding endpoints, we can see that again the P4 interaction was negative in both endpoints. But in subgroup, if we go in one step into the results, we can see that in the ACS group, the reduction of thrombotic events was much more higher, while in the non-ACS group, the reduction in the bleeding endpoint was much more higher, which shows that probably clopidogrel could reduce the more important outcomes in ACS patients, while it could be more protective in the non-ACS patients in regard of bleeding events. So when we go into risk, again, we think about the thrombotic risk, which can be defined as the ischemic risk, or the bleeding risk in patients. And again, this was a substudy that was done in the host exam trial. And regarding the stable patients, we could see that the high thrombotic risk had no difference in clinical outcomes, which means that after the patient is stabilized, there is no difference in the thrombotic risk, regardless of the thrombotic risk in patients. However, in the bleeding risk, we could see that clinical events occurred more oftenly in the HBR arm, which showed that in stabilized patients, the bleeding risk is much more important in the long run. If this was divided into the thrombotic and bleeding events, we could see that the HBR arm had a higher event rate of thrombotic composite endpoints and bleeding endpoints, which can also be shown that the HBR population is not only a high bleeding risk population, but also a high thrombotic risk population. The HTR arm, we could see that there was no difference in thrombotic endpoints. And also interestingly, we could see that the HTR arm had a slightly higher event rate of bleeding events, which also shows that the HTR and the HBR are a very similar risk population, which is slightly against the common sense that we have, which is HBR is on the other side of the HTR group. Again, when we divided this into risk factors, we could see that there was an increase in the outcomes by the HBR. However, the increase was not shown in the HTR group. When we divide this into aspirin and clopidogrel, we could see that both in the HBR group and the HTR group, there was a significant decrease in outcomes by using clopidogrel compared to aspirin, showing that clopidogrel was superior compared to aspirin, regardless of the risk, which was defined as HBR and complex PCI, such as HTR. Again, when this was divided into 4 groups by the presence of HBR and complex PCI, we see that the highest risk reduction was in those patients with the highest risk, which is those patients with HBR and complex PCI patients, which means that clopidogrel was better than aspirin in the highest risk patients, which means that this agent may be better compared to aspirin in this kinds of very high-risk patients that we treat in the clinic. So this is the last slide of my talk. I would like to say that the host exam trial and the host exam extended trial proved safety of clopidogrel monotherapy over aspirin monotherapy in stable CAD patients. And of course, only Korean patients were included, but the Korean patients are also all Homo sapiens patients, as Western patients, and as other ethnicity patients. If ethnicity were to be an important issue in this trial, then ethnicity should have been stated as an essential factor in considering treated CAD in previous guidelines or previous recommendation papers, but there was never stated as a very important issue. And I would like to say that high-risk features outweigh the significance of ethnicity, while we can see that the host exam study was consistent in these high-risk patients. So I'd like to say that ethnicity may be a minor issue, but again, the ethnicity is not a very important issue that we should consider when interpreting a lot of randomized clinical trials that we perform in the clinic. Thank you for your attention.